today, and I do like to be interrupted, so if you have questions, please submit them in the chat. Maggie will cue me up when questions occur, and we'll take a break and answer them so we can answer them in the context of the presentation. But we're going to have a little fun as we get started here, and as just make sure I can advance my slides here, okay? Okay, that did not work. Okay, so here's our objectives for the day, and I will let you read those. We're going to review why projects and initiatives fail, principles of leading change, and apply them to a typical healthcare project. And as Maggie said, there is a handout that you can download to provide you a framework that you can take these tools back to your health system or program or whatever you're doing and apply these starting tomorrow. So we hope you take advantage of that. So why am I facilitating this call? At truth, I'm really a country doctor. I practiced in Newport Richey, Florida for over a decade before I got into informatics. But I started my medical career, clinical experience as a physician assistant back in 1979. So I guess that would put me about 40 years in healthcare now. And as a surgical PA, got a really good insight into healthcare and went to medical school where I became a family physician. Practiced and started in a private practice and then expanded to a group practice. And back in 1993 was, as I believe, the first physician in the Tampa Bay area of Florida to implement an electronic medical record, and possibly one of the earliest in the state of Florida. This was back, some of you will remember 386 IBM computers. I wasn't on the internet until 1995, so it was pretty new technology. And a couple of things happened that got me interested in change management. First off, most patients needed to be coached to understand the importance of having a computer in every exam room. And so getting the patient engaged in the practice was a very important step. And over the next 2 years, I only logged one patient out of 5,000 that ended up leaving the practice because they were uncomfortable with a computer in the exam room. And this was a time that most people did not have computers in their home. The other big change management issue was my associate that worked with me saw approximately the same number of patients a day. And at the end of 30 days, I had cut my workday from 2 to 3 hours a day because I no longer had to dictate records and stay after each night and keep track of documentation, because I did it all within the emergency room, or within the examining room, I'm sorry, as I was seeing patients. And so at the end of my office hours, as the last patient went to the front to check out, I actually left the back door having all my work done for the day. And this counted for about 40 to 60 hours a month of time savings for me personally. My associate, however, did not use the EMR precisely as it was designed to be used in our workflow, and he ended up adding 2 to 3 hours a day to his workflow. And it was a very frustrating 6 months for him until he finally came around and asked me, I want to get like you, so show me what you're doing that I'm not doing, and finally was open to begin to understand that the EMR was not the problem, but it was his approach to how he was leveraging technology. And that's why I've become an expert in change leadership, because implementing technology is one step, but there's lots of implemented technology out there that nobody uses. And so understanding how to get change to occur, whether it's implementing a new program, implementing new technology, implementing electronic record, a new coding system, a new HR system, anything you do in healthcare, requires you to put some effort into change management, which is the science of helping people be led through change. And one thing we know about healthcare right now is that change happens just about every quarter now. We have new federal regulations, have new medications coming out, we have new guidelines and other external factors that are continually changing how we do work, whether we're a payer, a provider, or a health system. So also had started a company looking at how information flowed in healthcare, and I was the CEO of that company, and we studied healthcare transactions to fully understand, and this was really my full-time venture into informatics, and really began to look at why technology was so delayed in healthcare, and came to the understanding that healthcare transactions are very complicated in that there are multiple consumers of every transaction. And we used to say that healthcare transactions are not a linear process, point to point, but they're more like a pebble dropped in a pond with waves of information going out to the multiple people that need that information. So think about the complexity of healthcare, and you have people that provide care, people that support care, people that authenticate or authorize care, people that fill prescriptions, people that adjudicate charges. All these transactions are going on, but it's a little more complicated than a pebble falling into a pond. It's more like a tropical storm over a pond or over the Gulf of Mexico, and lots of transactions colliding and bombarding. And so that's why there's so much frustration today in healthcare. And it's only as we get a better handle on the digital healthcare environment through advanced clinical business intelligence and analytics to really understand what's going on. And that's the future that we're looking at. As I spent 4 years as Chief Medical Officer, have run multiple hospital departments, and having been involved in running a hospital, that's been a great experience to understand that side of healthcare. And then I've had approximately 12 years experience in 2 different roles as a Chief Medical Information Officer. I've automated over 60 hospitals, and all the hospitals in the last few years have all gotten to HIMSS level 6 or 7 very, very quickly. Since '85, I have been developing also some solutions in healthcare and doing the change leadership in multiple projects. And I've also taught this in a master's level program, taught change management and leadership as well as healthcare operations. So that's a little bit about me, so you understand this country doctor that's talking to you and why this field is so fascinating to me. So a lot of times when I publicly speak, and this may not come across as well in a webinar audience as it does as a live audience, but I've been using this picture for about 15 years because it's kind of an example of how we look at our biases and misconstrue what needs to occur when something happens. And when I ask people what's wrong with this picture, the audience will normally say, well, they've got square wheels, and someone will say, yeah, and they have round wheels in the wagon that they need to stop and put on the wagon. And people notice that these guys are really putting their back into their work. So one guy's pulling the wagon, and one guy's pulling, one guy's pushing, and they're moving forward in their wagon. And so the real point of this picture is what's wrong with it is that they're making progress doing what they're doing. And that's really why I talk about change management, because I see so many organizations moving forward, doing things the way they've always done them, and working much harder than they need to do. Back in the days when I started doing computerized provider order entry programs, and automating physicians from handwritten orders into electronic orders, typically those projects would take up to 2 years to do. And we were eventually able to get those down to 7.5-month programs, of which the first 90 days was really planning and only 4.5 months to really get most of the work done. So I'm going to encourage you today to think about what I'm saying and recognize that there may be places in your organizations that you are pushing the wagon with square wheels on it, not realizing that there are better ways to do things. So I'm hoping you come away today with some ideas that you can apply immediately in your situation, whether you're a coder, whether you're a hospital executive, whether you're someone that works with projects or programs, and can apply these principles to your own things. So, and I always like to use a little humor with this, and I'm a big fan of Gary Larson, who did The Far Side. And I think we all approach projects hoping for massive success, but sometimes even though our expectations are really high, we don't really bring the right tools to the table to get the job done. And although these spiders have a big vision of eating like kings, I don't think the tool that they're using is probably going to pull off being able to capture the toddler that comes down the slide on the other side. So I think most of us would admit that we probably have seen something in our workforce or our job experience, employment history, where we've seen some type of new initiative or a business fail or a program fails. And so failure is part of what we face day in and day out whenever we take risk and try to do things. And if we are looking on why do projects fail, what are the key ingredients, most of us would give things like, well, it was the wrong problem to begin with, or our leadership just not that good, or maybe we didn't have the right people on the team. Boy, it's just not the right time, we're ahead of it, or we've got too many other competing priorities going on. We don't have the right resources. We're not messaging it very well. But what I want to postulate to you is that maybe these are just excuses, and instead we should say maybe management and leadership, we can do a better job and mitigate all these problems so that we can move forward. So the science of change leadership is really, it's the art and science of helping projects and initiatives and manage the people side of it to help align them so that the processes and technology that we're applying go more smoother. So we do deal with the technologies and the processes involved, but we spend a lot more time working on the people side. And why? Because at the end of the day, there are people that are end users of anything that we use, whether they're our customers, whether they're our employees, our staff, our colleagues. Everything that we do has someone downstream that needs to adopt or to benefit from the effort of what we're doing. So, are there any questions to this point? Please feel free to put them in the chat. And then I'd like to show this one last slide for fun from Dilbert, because I think it kind of sums up that a lot of times people go to webinars and they end up coming back excited and they want to share information, and they get a little too exuberant and get in more to the fad of the week. So I'm hoping that the information that I give you today will be seen as more strategic, and therefore you can take it back and tactically apply it to your organization and create some real change, and not just create something that you think about for the next hour after this webinar and then go back to doing things you've always done. So Cotter wrote a great article back in '95 in the Harvard Business Review, and he outlined these 8 reasons that projects fail. Now, before I go there, Maggie says we do have a question. So Maggie, what's the question?
The question is, they were wondering how change management is different in healthcare than it is from something such as software engineering or some other related field.
Yeah, great question. And it's probably not that different. The difference is really the science and the principles of change management should be the same, but in software engineering, we often think of change management around change control. And change control is a part of change management, a subset. And so when you talk about change management in the bigger sense, we're not just talking about change control. Now, for those of you who know what I mean by don't know what I mean by change control, anytime you're working with software, databases, architecture, you have to have a methodology to manage changes to your system. So if you're building a building, you may decide that you have your original architectural plans, your blueprint that you've approved, but as you're building the building, the client says, I want to add an extra storage closet, or I want to change the air conditioning in this room to make it a colder room because we're going to put software servers in it, or I want to add an extra handicap restroom. So in change control, you have something that's submitted. Then you assess the viability of that change. What's the impact of it? What's the cost of it? What's the effect on your project plan? In this case, building a building. Is it going to cause delay? What's it going to cost? What resources are needed? Do I need to take drawings back to the city to approve it? And then you approve the change, and then you implement the change. That's what we would call change control. When I'm talking change management, change control is a piece of change management, but change management should look at the bigger part of when you're engineering software, how are you going to get that software to the point that it's actually used by people, adopted, bought, and deployable. And in the case of we know that many organizations implement software that they either don't use at all or they use only a small capability of it, and the employees end up going back to doing things they've always done through the process of what we call workarounds. So if you really want to make lasting change and get something that's adopted and creates enormous value, that's where the science and application of change management and change leadership really comes about. So how do you get an organization to accept change without rebellion, without resistance that stops your progress, which derails the project, that causes it to go into overruns, cost increases, delays, or even get canceled altogether? So I hope that answers the question to the person. But the principles of change management are the same whether you're in warehousing, distribution, or in healthcare. So there are 8 principles, and they're actually numbered in the order of priority. So this article was actually written about why efforts fail. And so in a little bit, we'll turn it around and say, okay, so what do we do to mitigate it? So let's talk about each one in detail. We're going to spend quite a bit of time on this. And not establishing a great sense of urgency. So yesterday I was with an organization that had a vision for something they want to accomplish in 2021. Now the problem with accomplishing something in 2021 is that's all grand, and often our strategic plan lays out 2 to 5 year goals, but people don't react and get motivated by projects that are 2 or 5 years out. They get more motivated by things that are more urgent. And I'd love to share that great story that was originally told by Hiram Smith. And some of you will remember Hiram Smith as the inventor of a tool we used to use in the pre-smartphone, pre-PDA age called the Franklin Planner. And it was a tool that many of us used in business to keep track of our calendars and notes and things. And Hiram Smith would lay a 30-foot I-beam, steel I-beam, on the floor in the front of an auditorium when he was giving the talk. And he would ask the audience, how many of you would be willing to come up here and walk from one end to that I-beam to the other, 30 feet, on that I-beam, sitting on the floor here for $200. And of course, many, many people said, everyone would pretty much put up their hand and say they would love to do that. And then he would say, and this was in pre-9/11 days, he would ask, okay, so I've got the next challenge for you. I'm going to bolt either end of this I-beam to both the Twin Towers of the World Trade Center in New York. And I'll pay $200 for any of you that are willing to walk across this I-beam. Will you walk from one building to the other across a 6-inch wide I-beam for $200? Now, of course, if you know anything about the World Trade Centers before they unfortunately came down, that, you know, it was typically, you know, damp up in that area. There might be light rain, water on the I-beam. The buildings sway, so there'd be sway. There'd be breezes up there, you know, 1,500 feet up in the air. You can imagine what that's like. But if I asked the audience right now, I would think that none of you would be willing to walk across that I-beam for $200. So he would then change the situation and say, imagine this a little different. If you're a parent and I had your 2-year-old child and I was on one tower and you were on the other tower, and I was holding the kid by their collar right at the edge of the building and said, if you don't cross over this I-beam in the next 5 minutes, I'm going to drop your child. Now, it sounds like a very horrible sight, but I think in that situation, most of us would immediately act, and we would move across that I-beam no matter what to save the life of a child. Now, of course, if it was our teenager, we might question that, but for the life of a child, we create a great sense of urgency, and you know the job is more likely to get done. And so when we're looking at projects, and I once had a person I worked with that says, I want to change the culture of my organization over the next 2 years, and here's my plan. And knowing that a sense of urgency is probably the biggest success factor of any project, I actually said, I don't think you change culture over 2 years. You really change it over 90 days. And he didn't believe this, but it's been shown that you really can't make people sprint for 2 years, but you can get them to do great sprints over shorter periods of time. And most people really do better when they have short periods of time, 2 weeks, 4 weeks, 40 days, 90 days. In fact, in the Bible, God changed the culture of the world with 40 days of rain. So we know that there's plenty of models that urgency plays a role. And often projects fail because no one realizes why they should put work on it at the moment. And I'm sure every one of you have what I call over-the-fence projects or drop-dead projects or things that have to get done. We used to call them fire drills, where all of a sudden you're working on something and something more urgent comes up, and what do? You drop everything and you work on that immediate need because that sense of urgency has moved that up to the priority list. And so often we don't think about this with longer strategic projects, and we don't create any urgent milestones along the way and really communicate how important that urgency is. So think back to projects that you've had, and you'll probably come up with some examples in your own life of where no urgency was really created. Now, the other things that organizations do is they create these great strategic plans, and then the fire drills happen on a daily basis, and they pull everybody to go work on the fire drill, and they leave nobody working on the strategic projects. And so it's important that you know what the important work that you do, and then not take all your day and all your urgency in working through the fire drill, but make sure you put a little time on your strategic projects. And you'll only do that if there's also some urgency applied to it. I'll pause and see if there's any questions on that or examples that anyone wants to share. Okay, and I hope that example of the I-beam helps you to remember this. The second point is not creating a powerful enough guiding coalition. This has been critical to the major projects I've done, and some of these projects have been, 100 million plus projects, some of them over 3 to 5 years, as much as $450 million projects. And a guiding coalition is really a group that owns the success of a project. And so what I've done through the years is divided up the key work of a project so that there was a champion over every important area of change management. So what are these areas? So most people think change management is only about communication. Communication is important, but it's not overly important compared to all the other ones. And it's really the team or the guiding coalition that creates it. So one structure I have found successful is that major projects that I do need to have what I call an executive sponsor. The executive sponsor is the person that's ultimately responsible. That is often the CEO of a organization for an enterprise type of project, or some high-level leader over a business unit that's trying to perform some project or initiative. That person should have the ultimate ability to make decisions, to override decisions, and to make sure and to help the organization remove obstacles that may be in the path. So they need to be a person of influence and a person of authority enough to do that and be able to work with others, because often the obstacles occur across a different business unit or sometimes even across a different enterprise. Now, other champions then that need to work with that executive sponsor, so let's just go through those. The first one is the stakeholder champion. And the purpose of the stakeholder champion is to identify who the stakeholder groups are really in the end product that you're developing. So if you're engineering software, you may have one type of user or you may have multiple users. So let's take something like if we were designing an accounting program like QuickBooks, who would our stakeholders be? Our stakeholders might be customers that use QuickBooks for their home accounting. They might be small business owners. They might be small businesses. They might be bookkeepers. They might be accountants. They might be tax professionals. And I could think of probably a few others. But not all those stakeholders have exactly the same needs. And also, not all those stakeholders have the exactly the same level of education, awareness of what you're talking about. So often, they're going to need different education. They're going to need different features. They're going to need different engagement to tell the story of why they should buy your product. Likewise, when we're implementing electronic medical records to an organization, our stakeholders in the hospitals are typically doctors, nurses, unit secretaries, ancillary people such as lab and radiology departments, patients who are going to be most impacted, hospital administrators, the finance people that need to get charges, and people that do scheduling, and people that do supply chain. And they all have different needs and will all be impacted differently. And so the Stakeholder Champion is really to identify who the stakeholders are, and then within those stakeholder groups, identify who are the people of power and influence in each stakeholder group. Because the people of power and influence become your key influencers to message as you're engaging those stakeholder groups. So for instance, when we're implementing electronic medical records, the message to doctors is quite different than the message to nurses. Nurses are working all day in the hospital, employed by the hospital. Doctors are usually not employed by the hospital or weren't in the past, and they're usually interacting with the hospital an hour or less a day, sometimes longer if they work within the hospital, but their interactions are completely different, just like everyone else I mentioned. And the role of the Stakeholder Champion is to identify who those people are and to begin to assess the needs. And then they work hand in hand with what's called the HR Champion. And the HR Champion's job is to determine how those end users will be impacted by changes in workflow. And as people's workflow change, we tie that into both communication champion and into the what we call the workflow champion. Now, why is this important? Well, when you're creating something that's going to change the way people do jobs, you have to know, is this going to change their core competencies? Is this going to change their work schedule? Is this going to change how they do their work? Is it going to change how you evaluate their work? Is it going to change the hiring criteria? And is it going to change their performance evaluation? And we could name a few others. So for instance, when we're implementing computerized provider order entry in the hospital, we know that the unit secretaries or unit clerks are going to have 60 to 80% of their job redefined, because their role of pushing paper orders and paper charts and assembling charts is going to go away and be replaced with new workflow. So we have to understand how it's going to impact them, how it's going to impact training, onboarding, evaluation, and their day-to-day work, and perhaps their job responsibilities will grow. And I always like to use the example of rental cars. Most of us who have been around a few years remember that 20 years ago, when we would return a rental car to the parking lot at Advize or Hertz, we would go drive into the parking lot. Typically, someone would check the car in, take the keys from us, and then we would go into the counter and stand in the counter and wait till the paperwork was done to check us out and get us a receipt. And the person that took our keys, when they're not parking cars, they're probably in back washing the cars and vacuuming them, getting them ready to be rented out again. Now today, if you drive into Advize or Hertz, the person that meets you in the parking lot is actually running a very sophisticated microcomputer that is on their belt. They pull it up, they scan the VIN number of the car, they greet you by name, they ask you, were there any issues? Did you fill up the tank? And they greet you by name and ask you if you want to use the same credit card that it's on. And then they print you a receipt. And their job is pretty much to do that process all day long. They're not the people that wash the cars, and you as a customer are smiling as you're getting to the terminal faster to check in for your flight, and you're no longer having to go and wait in another line to get that done. But you can imagine when they implemented that at Avis and Hertz that they had to look at their workforce, decide were the people currently checking the cars in the right people to run the microcomputers. Some were, some weren't. They had to do new training programs, and certainly their evaluations, their level of customer service, their game had to improve because they were having more interactions, dealing with financial corrections, transactions, and making sure everything worked, even when sometimes the microcomputers fail. So you can see how their job descriptions, their hiring criteria, their evaluations, and probably their pay scale all had to change. And so the HR champion is understanding with your initiative how that's going to change the way people do work and all the ramifications from an HR standpoint that has to do that. The third thing is lacking a vision. And while most organizations have a vision statement and a mission statement is who we are, and a vision statement is who we're planning to be at some point in time, often we don't take the time to write a vision statement for a project. And why is a vision statement important? Because we all get motivated when we understand why we're going to do it. And so many times in projects, we deal about the what, we deal about the how we're going to do it, and we talk about when we're going to do it and with whom we're going to do it. But we tend to underestimate the power of why. But if you really think about it, like I said with the example of the child being dangled over the World Trade Center tower, the why is probably the biggest motivating force. And the why is also what helps us to understand when we come to a crossroads and we're faced with two or more options of what we should do. Our vision statement makes it clearer on which option gets us closer to our vision rather than the option that may be easier at the time. And so we should always evaluate when we come to the fork in the road, not what's the easiest path or the path of least resistance, but which one is going to help us best achieve our vision. And if we don't provide our people with a vision of what we're doing and help them to internalize that vision, then they will not be as motivated and performing as high. I remember a story I read in a book probably 20 years ago about a reporter that interviewed 3 guys with shovels that were working in a big excavation the size of the city block. And the person asked the first person with the shovel, "Sir, what are you doing?" And the guy answered him, "I'm digging a hole." And she asked the second person, "Sir, what are you doing?" And he said, "We're digging the foundation for a building." And when she asked the third guy what he was doing, he said, "I'm building a cathedral." Now, hearing that, which one do you think would be the most motivated? The person coming to work every day to dig a hole? Often, we give people the idea that they're part of building a building. But how often are we taking the time to really help our people understand that the project we're doing is building a cathedral and what the benefits are and how it's going to provide value to them, to other people in the future, and how it's going to serve your customers or mankind in general. And when we give people those visions and help them to internalize those visions, and they come to a difficult patch or an obstacle that has to be overcome, we're going to be more successful overcoming those obstacles if we have a big vision and everyone in the project. And I often see projects where the leaders have great vision, but the end users or the people within your teams, your staff, your coworkers, they don't know what the vision is. They merely know that my boss tells me I got to do this, or we've got to get this done by this date and time on this budget, but they don't really have a great vision that's been internalized that motivates them even when their boss isn't there to push them. So vision is very, very critical. And then following from vision is the fact that we need to over-communicate the vision and really keep it in front of people on a daily basis. When we're automating hospitals, my number one concern is patient safety, and everything that we should do around healthcare should be around, can we make the system safer? And we should always be talking about patient safety. But for a specific project, there's probably a more specific vision that can be done, and they need to know how that this project is going to get you to the vision. So not only why the vision is important, but how each step of the project or each milestone is going to contribute to the success and get the results that you envision. And so only by over-communicating it will you keep people mindful of the reasons of why they're doing it. And often people find, especially in long projects, and I define a long project as 6 months to 2 years, people often forget about the starting vision because it's not kept in front of them, and a lot of fatigue sets in and you get a lot of obstacles coming up. Which brings us to the next point, which is not removing obstacles to the new vision. Probably the best obstacle statement I've ever heard is, well, Dr. Phil, that's not how we do it here. Or, you don't understand. Or, I'm not going to do it. So obstacles can be attitudes as much as they can be existing policies and procedures. They can be other things that fall into the path. Hospitals get fined when they do surgery that is billed as outpatient surgery, even though Medicare defines it as an inpatient operation. So Medicare has a list of 1,600 or so operations that you have to admit the patient the morning of surgery and do their surgery as an inpatient, because you already know these are inpatient operations. Things like total hip replacements, things like total heart valve replacements, cabbages or coronary artery bypass surgery, colon or large bowel resections. These are all operations that the patient's going to need to stay in the hospital at least 2 days, probably 3 to 5 days, sometimes longer. And Medicare, since about 4 or 5 years ago, has refused to pay for the operation if people bring the patient in as an ambulatory case and then only admit them after the patient is post-operatively, because they looked at this as an effort to unbundle the charges and to charge the operation separate than the DRG. And so they have made this rule. And I recently worked with an organization that didn't know that rule existed. And after informing them that it existed, they still didn't change, even though they were losing hundreds of thousands of dollars a year in non-reimbursed surgeries, and really getting down to why they were doing things the way they did it was because they had created a policy and procedure about 20 years earlier that all patients had to come in as an outpatient into the same-day surgery and only got admitted post-op. And that was a rule. Everyone knew the rule, and everybody had to operate to the rule. So no one ever communicated to the frontline staff in the perioperative areas and the registration that the rules had changed, and who knows how much money was lost because of not knowing the rules. But obviously someone knew the rules in the organization, but no one communicated it. And policy and procedure, in fact, was purposely not meeting the regulation because it was based on an old rule. And I remember a story I heard years ago about a Chevrolet plant where they had a problem with the windshield leaking in a model of car. And the interesting thing was they found out that not all the windshields leaked, but about 90% of them leaked. But they found that one production team on one shift at one assembly plant did not have windshields that leaked. And so they hired efficiency experts to go and watch this one team assembling installing the windshields into these new cars on the assembly line. And as they were going through the checklist, they did step 14, they did step 15, then they did step 18, and then they came back and did steps 16 and 17. And the efficiency person asked them, well, why are you not following the manual and doing step 15 and 16 and 17 in sequence? And the shift supervisor said, well, if you did that, the windshields would leak. And so here was one assembly staff that literally knew there was a problem, but it was never communicated back to management that there was an issue, and cars had to be recalled because they were being assembled wrong because someone had laid out the process incorrectly to actually create a situation where the windshields would leak. And that happens every day in our hospitals and health systems and organizations where we are doing things that don't make sense. And they are obstacles. And we typically think obstacles as people and policies, but they're often part of the culture and part of how we do things that are keeping those square wheels on those carts and keeping us from being successful in what we do. Sixth is not planning for and creating short-term wins. Everybody needs some form of celebration. You've got to have a way to move forward and help people stay energized. In fact, some organizations actually call them energizers. Short-term goals that get done and then get celebrated for getting it done. And these are very, very critical to help people stay motivated and stay focused on the task ahead. And often projects lose momentum when you don't celebrate those short-term wins. And sometimes good people move on to other organizations because they're not being recognized. Declaring victory too soon. The example I always use from this is after the fall of Baghdad in the Iraqi war, President Bush flew to the aircraft carrier USS Abraham Lincoln, and there was a large banner across the superstructure of the SS Lincoln, USS Lincoln, that said "Mission Accomplished." And the press went after this and claimed that this was declaring victory too soon. And it's interesting because most people don't know the true story, so I'm going to play Paul Harvey a little on this one. Because the rest of the story is the mission accomplished was because of the reason that George Bush was on that aircraft carrier that day, was because that was the last day of combat mission for the USS Abraham Lincoln. And they were leaving the fleet and going back to Norfolk, Virginia, where the ship was going to be decommissioned. And he was there to celebrate the crew, their years on sea, and these 5,000 men and women on an aircraft carrier who had so bravely served our nation and had participated in the Operation Iraqi Freedom, and was now steaming home to port with their nuclear reactor, and to honor the men and women on that. And in fact, in his speech that was never relayed, but you can go out on the internet and check this, he actually begins by saying the war on terror is something that's going to last for years, if not decades, and we've only just begun to approach, what we need to do. But we're here today to celebrate your mission being accomplished, and it's a very good speech. But we all know that sometimes we declare a product to be ready, we know something to be done, and then we find out that there are defects, there are things that have not yet been fixed, and we declare our victory too soon. And we miss some hiding defects or obstacles that have not yet come up. So it's important not to get out in front of this and to really do what President Bush did, which was declare the right victory at the right time, and not what the press did, which is try to declare a victory for something else that it was not intended to. But we tend to overstate, and we see this every day in the stock market where people are overstating returns. Enron was a great example of a company that failed declaring victory too soon. And there's many, many other cases. And the final one is not anchoring changes in the corporate culture. And we know that if we don't change our culture, things will stay the way they've always been, and we'll keep getting what we've always got. We'll keep those square wheels. And because the culture, our corporate culture, is where people want to keep doing what they've always done. They want to work around your new processes, your new procedures, and they want to keep doing the same old things. Now, which reminds me, back to my guiding coalition number 2, I didn't finish the other champions that I think you need in your team. The other champions are a workflow champion who's responsible for knowing what the current states are and for mapping out what the future states are going to be and making sure that that is communicated. There should be a communication champion. Communication should always be ongoing. It's important in a major initiative that everyone is singing the same song. That's why a communication champion should be responsible in what the message is for the next 30 days and should be communicating so that if the leader of the team or a team member or the CEO of the company are asked, how's the project going, everyone knows the same answer, so that we don't create confusion in messaging and that we don't have multiple people saying different things about what's going on with the project, because that creates confusion. The final one is training and education, and that is basically working with the stakeholder champion, the workflow champion, and the HR champion to decide what do the end users need to know, how are their jobs changing, and that team usually creates what's called a start, stop, continue document so that you've documented out that when your initiative or product goes live, what am I going to start doing that's new? What am I going to stop doing that I don't need to do anymore because that work has been eliminated? And what do I continue doing because that work stays the same? Start, stop, continue documents. So those are the 8 methods. We're coming up on an hour, and I want to leave time for questions. But there's a handout as you're thinking of your questions that I've put out there on the website that you can download. It's a grid. It's 2 pages. It's got the 8 things laid out in a more positive sense, and it has 3 questions across the top. And I encourage you to look at something you're doing right now and take each of these 8 things and fill in a self-assessment of what are we doing well around urgency, what are we not doing well, and what shall I do better as a result of this. And go through each of those: urgency, guiding coalition, vision, over-communicating, removing obstacles, short-term wins, staying the course, and anchoring. How are we doing those 3 things? How are we doing? What are we doing well? What are we not doing well? What should I do better? So with that, Maggie, let's open to some questions, and we'll take it from there.
Great, thank you, Dr. Phil. We do have time for some questions. I don't see any in the panel, so if you are sending them in, please make sure that you send them to all organizers so that Dr. Phil and I can both see the questions as they come in. If you are typing out a particularly involved question, please feel free to raise your hand so that we know there are some coming.
And those who don't have any questions, thank you for participating. We appreciate it. If you want some links to some case studies, you can visit my website at www.medmorph.com.
We are receiving a few questions now. We have one that says, as you stated before, not everyone is on board with change. How do you suggest getting people on board to help facilitate those changes?
Yeah. Well, I think the reason most people aren't on board with change really comes around to not understanding the clear vision of why we're doing something. We spend an awful lot of time in healthcare talking about what we're going to do and when we're going to do it and how we're going to do it. We do not spend enough time really talking about why we're going to do it and identifying what the value is going to be with each member of our team and with the end users of this initiative. That's why we get so many projects that go out there. It's estimated in healthcare that 80% of IT projects fail. And it's really because people are not applying these principles. And the one that urgency is an important motivator, but number 3, clear vision. Often I cannot get a clear vision. And over the last few years, I've been spending a lot of time coming in to redo failed initiatives. And it's been very clear. One initiative I recently did had been 8 years of failures, and obviously people were even less motivated to be successful after experiencing failure. But when you come in and you establish a vision, you leverage these 8 principles, you can go and you can move mountains and you can get people engaged and really involved. But you got to find what it is. And I have 4 principles that I use in informatics. And my first principle is that everybody in healthcare every day comes wanting to do the right thing for patients. And that's really the law of inward calling, higher calling. People in healthcare work in healthcare because they feel that higher calling. And that's really, really important. Second rule is everyone in healthcare every day comes to work listening to the same radio station, WIIFM, what's in it for me. And the purpose of saying that is even though everyone in healthcare is there for the right reasons, when it really comes down, we are more motivated by self-motivation. So we put our time, energy, money, and peace of mind into the things that give us the most satisfaction. And even though we are there for a higher calling, we still end up doing things that motivate us the most. And every day we have 24 hours that God has given us, and we prioritize those 24 hours based on things that we decide to prioritize them on. And yes, we have external motivations like a job, like a boss, like a spouse, like a teacher, other people that sometimes drive our timelines. But at the end of the day, we do it or we don't do it out of choice. And that's that internal motivator. So we need to spend more time creating a strong vision and drill that vision down into value statements so that every stakeholder group knows what the value is, the what's in it for me, so that the value of doing it or getting it or learning it is going to be greater than the pain of leaving behind something that they're currently doing, because otherwise people will stay right where they're at.
Thank you, Dr. Phil. At this time, that appears to be all the questions we have received. I have one that may be of interest to perhaps people who are on their way up to becoming leaders in the space. How would you recommend they affect change or get executives to buy in on their ideas when they're presenting them?
Yeah. Well, that article I put at the very beginning, The 8 Reasons Projects Fail by John Cotter, that's readily available on the internet, and you can download that article. It's from the Harvard Business Review from 1995. It's been out there 20 years. And I would download that, and I would start sharing that with my team, my colleagues, and get people to start reading it and sit around and talk about it and say, how could we do better? And at some point, the person above you is going to say, yeah, you're right. We need to be talking about this. And no matter where you're at in an organization, you can still lead change. So you lead yourself, you lead your peers, and you lead people that report to you. So John Maxwell, the great leadership guru, wrote a book called 360-Degree Leadership, and he says no matter where you're at in an organization, you're leading up, you're leading across, and you're leading down. So you can encourage your leadership, and you can leave a copy of that article, or even as a team, you could write together your ideas, fill out the grid that we gave you as a handout, fill that out on the initiative and that report card, and you can even anonymously send it to your leader on your appraisal of what's going well with a copy of that article. And it's a great motivator. It's a great way to impact people. But the best way is always the open way. And change your organization by helping people understand better what your own needs are and how to meet the needs of others. A great motivational speaker, Zig Ziglar, said, if you help other people get what they want, you'll always get in life what you want. And that's so important. And you can lead change from any level in the organization or project.
Great. Thank you. That appears to be all the time we have today. I would like to thank Dr. Phil for giving us a great session on change leadership, and thank you to everyone in attendance for today's webinar. You can be sure that we will have Dr. Phil present for us once more in September and again in October. The next webinar is on population health and solutions to hospital readmissions. Again, that will be led by Dr. Phil Smith. A registration link to this presentation will be provided to all attendees in an email that contains a recording of the session and a survey that we would like everybody to complete for us so that we can create a more robust and engaging webinar experience. You can expect these items within the next 2 business days. If that is all Phil has, we can end today's session.
Okay, thank you very much.
Great. Thank you, Dr. Phil, and thank you, everyone. Have a great afternoon.